The next. Next, please. So next, please. Next. Okay. This is what I was talking about. Just a moment. This is what I was talking about in those countries where nephrologists act as as access surgeons in India, in Germany, and Nepal. The next, please. And this paper shows us a large proportion of vascular access operators as nephrologists in Italy and in Japan that impacts in the median time from referral until access creation that varied from 5 to 6 days in Italy, Japan, and Germany to 40 or 43 days in the UK and Canada, where the main actor of the vascular access was the vascular surgeon. Next, please. In our paper, we described a series of cases, was 159 AVF with a patency rate for hemodialysis near 70%, and the major of a proportion of procedures was made at the forearm. We have only 1.25 complications. Then the most common was the arterial steal syndrome that was resolved in all patients as we made the ligation of the fistula with no additional harm to the patients. The next, please. And you may be thinking, what's the ideal training to become a clinical expert as nephrologist to a vascular access surgeon? The next one. This paper published by Goodkin and colleagues from DOPS data, they stating that the relative risk of AVF failure was higher for those surgeons who had placed less than 25 AVFs in training. For those who had placed more than 25 AVFs, with a significant difference between the two groups. This suggests that 25 AVFs performed in training allows for comparable outcomes in AVF formation compared with consultant surgeon practice. The next. Thank you. And in my training, I accompanied as an assistant to the vascular surgeon about 110 procedures. And in our study, after dividing the construction of fistula in 3 consecutive periods, we found that AVF success rate was equal in the 3 periods and was not associated with the nephrologist's surgical experience. The next one. It's being detached here. There was no difference between the periods. The next one. And what's the problems dimension here in Brazil? So for this presentation, I took my reality and I intend to show you my reality, and you can apply as your reality permits. The next one, please. According to the 2020 Brazilian Society of Nephrology Census, we had almost 145,000 patients on dialysis in Brazil, of which 93% was on hemodialysis. And roughly, we can have a number of 98,000 patients using an AVF for hemodialysis in Brazil at this time. The next. And in our state, Minas Gerais, next, we have the attendance of health divided into many regions of attendance. And this is our region, which is composed by 15 cities. The next one, please. And Barbacena, my city, is the head office city of a health region. And we make attendance of a population of 237,000 people, divided in these 15 cities, including Barbacena. The next one, please. And for this region, our clinic, ProRenal, is the dialysis referral. The next one. And We are responsible for hemodialysis and peritoneal dialysis of this region. And we also have a clinic of outpatients with chronic kidney disease, stages 4 and 5. 93% of, thank you. 93% of patients on hemodialysis are from the Brazilian public health system, SUS, which one has many problems with the financing of hemodialysis in Brazil. The next. And our vascular access situation, we have at this time 168 patients on hemodialysis, of which 112 patients have an AVF functioning. We have only 3 AV grafts and non-tethered catheters. And of these, 6 already have an AVF on maturation. But I think the main impact of our service is in the outpatient of the clinic from chronic kidney disease, when we have 33 chronic kidney patients with an AVF waiting to start hemodialysis. And in the last month, none of the last clinics patients who started dialysis did it by a catheter. All of them did it by a fistula. The next. In our assistance model, the interventional nephrologist is responsible for the initial evaluation of the patient, the access creation, and the postoperative follow-up. We also do the monitoring of all patient vascular access from the clinic. And recently, we had one vascular surgeon added to the team to make the more complex surgeries as AV grafts and treat the complications of the AVFs. The next. Well, in our service, we take a clinical history of the patient. We do a targeted physical examination, and we do also an ultrasound examination in all patients. And we record this data in planning sheets. The next. This is a picture of a patient with a tourniquet in his axillary region, showing an unusual veins. The most of our patients do not have this vein anatomy. They had veins that was not so easily to see. The next. So we do the ultrasound examination, measuring the cephalic vein in 3/3 in the forearm and in the arm. This is a cephalic vein at level of the wrist. Next. And the basilic vein and the cephalic vein, we also measure it at the level of the arm in 3/3, the distal, the median, and the proximal. Next. And once had measured the venous system, we do the examination of the arterial system. We start at the radial artery. We do a measure at the level of the wrist. The next. And we do a Doppler ultrasound. We must have a 3-phasic pattern that excludes the hand ischemia. The next. We also do a Doppler ultrasound at the ulnar artery, excluding also the hand ischemia. Next. Once made this, I take a measure from the brachial artery, and also the next, doing the ultrasound Doppler.
Hace el ultrasonido de Doppler que debe mostrar, como ya indiqué, el patrón de 3 fases. Siguiente, por favor. Ahora, de las mediciones de referencia, yo he usado la vena cefálica en la muñeca con 2.0 milímetros y la vena cefálica del codo con 3.0 milímetros. La arteria radial con 1.6 y la arteria braquial de 3.0. Siguiente, por favor. Ahora, estas investigaciones demuestran que el diámetro de la arteria y la vena de 2 milímetros al nivel de la muñeca es una guía razonable para realizar una ABF del antebrazo, pero la creación de esta ABF no debe ser abundante, por decirlo así. No debe ser abandonada, disculpen. Y este es el registro, ¿no? Obviamente está en portugués, pero aquí nosotros registramos toda la información de nuestros pacientes en la evaluación preoperatoria. Obviamente tiene la historia clínica, contiene las mediciones de los ultrasonidos para el sistema venoso, para el sistema arterial, para la examinación vascular y también tenemos un cronograma quirúrgico. Marcamos también qué procedimiento estamos marcando para cada paciente. Siguiente, por favor. Y en esta última hoja se hace un dibujo o un gráfico para poder determinar el día de la cirugía con qué vaso vamos a crear esa.
About our surgical technique, we make anastomosis vein to artery and then to site. And we do not use the Bresch and Cimino technique that is side-to-side anastomosis. Next. We do a vascular ultrasound mapping prior to the procedure. Then we make arterial and venous marking with permanent ink pen. And we do the antisepsis with chlorhexidine and local or regional anesthesia as the procedure need. Next. This is our surgical instruments. You may see that's not a lot of instruments. We use surgical clamps. We use some forceps, some vascular forceps, atraumatic, some scissors and retractors, and all of these instruments is used in our procedure. We do not have a lot of pieces. The next. We're starting to making a continuous line at the trajectory of the vein and the dotted line at the trajectory of the artery. Next. After this, we do the antisepsis with chlorhexidine. Next. And then we make a local anesthesia with a solution using normal saline and 2% lidocaine. Next. After desiccating the vessels, we have here the suture of initiating the suture of the anastomosis. It's important at the vein, we do the suture from outside to inside. And after this, the next, at the artery, we suture from inside to outside. Next. After doing this 4 or 5 times of each side of the arteriotomy, we have this aspect of the parachute technique when we pull the both sides of suture, coupling the angle of the vein to the angle of the arteriotomy. Next, please. After suture the both sides of arteriotomy, we have this final aspect of the anastomosis. Next. And once released the blood flow, we must have a thrill and then enlarged vein at the site of the anastomosis. The next. This is the final aspect of the wound. The next. For brachiocephalic fistula, we do this type of incision. The next. That can make easier to desiccate the cephalic vein at the level of the amble. As we desiccate next, please. As we desiccate the brachial artery, and after, next, we can make the anastomosis at this level. Next, please. This is the final aspect of the wound. Next. And for brachiobasilic fistula, we do a large incision at the level of the arm. It's to facilitate the desiccation of the basilic vein from the elbow to the axillary region. And after we make the ligation of all tributaries. Next, please. We have this aspect of an arched vein in a subcutaneous tunnel. And after this, we make the anastomosis to the brachial artery. Next. Next, please. And at the level of the forearm, you can also use the basilic vein. Next. After dissecate the entire vein, we can also make a tunnel. Next, please. We can also make a tunnel and transpose the vein at this tunnel and make the anastomosis to the radial artery. Next. This is the final aspect of the wounds. Next. Next, please. This is the patient at the 7th day postoperative. And next. At the 3rd day, after 30 days, he's using the fistula for hemodialysis. Next, please. Next, please. So in our service, we also do the postoperative evaluation of the patients and assess the AVF maturation status and make the treatment of the complications. Next, please. This should be a movie where we can see the aliasing inside the vein, showing us a turbulence that is proper from the fistula, a well-functioning fistula. Next. And we also use the Doppler ultrasound to calculate the flow volume of the fistula if it achieved its maturation. The next. This is the treatment of some complications that we initiate to do these more complicated surgeries at the last years. It is not for the beginners. And in this case, we treated 3 large aneurysms at the vein of the fistula. Next. After exposing it, next, please. And do the excision of the aneurysms. Next, this is the final aspect of the wound, and this patient evolved very well in the postoperative period with no complications. The next one. This was a very serious case with an infected pseudoaneurysm. When we have to, the next please, we had to make the ligation of the radial artery at the proximal, at the distal, and the distal site. And after this, we can clean the wound and make the approach to the abscess that was formed. Next. This was the final aspect of the wound with the abscess already cleaned. The next. This was to be, this should be a video when we show that the perfusion of the patient was maintained after the surgery, because prior to the procedure we made an ultrasound showing that the ulnar artery was capable to maintain the perfusion even with the flow at the radial artery blocked. The next, please. This was also a movie that shows a large pseudoaneurysm at the level of the vein of the fistula. In this case, I counted with a vascular surgeon with me, and we treated this large aneurysm with the excision of all vein in the aneurysm. The next, please. That was the postoperative aspect of the wounds. And the next, and the patient also evolved very well in the postoperative period with no more complications of this pseudoaneurysm. The next one. And lastly, I made a training on endovascular treatment of AVF stenosis, the angioplasty. And in our service, we do not count with an C-arch. Then we use the ultrasound to guide our procedures. The next. This paper published by Ricardo Portioli Franco from Curitiba, Brazil, and his colleagues, shows us vascular interventions using ultrasound to make thrombolysis on thrombosed fistula, and they use the ultrasound to guide the procedure. As well, you can use for treat the common stenosis. Once the most part of stenosis is peripheral and not central stenosis. The next one. This is my training with Dr. Domingos Chula and Dr. Ricardo Portioli in Curitiba, using the fluoroscopy to do the angioplasty and the ultrasound to do as well. The next, please. This is our current data. This is not published data. And we already made 600 fistulas and 104 intervention. And this intervention includes the thrombectomy, superficialization of veins, ligation of tributary steel syndromes, the treatment of aneurysm and pseudoaneurysm. All this is included in AVF intervention. We already have also installation of tunnel catheter in 178 patients. And our service do not have a large number of patients in peritoneal dialysis. As you can see, I only made 10 procedures. The main focus of our system is on hemodialysis. The next one. And according to the Brazilian regulation, you can also make a question if the nephrologist, can the nephrologist do the AVF surgery? And the answer is yes. The Federal Council of Medicine and its regional from Bahia understands that the nephrologist can do, with no technical or ethical issues, the surgery of AVF. The next one. And also the table of procedure from Census recognizes the nephrologist as a doctor who can also perform the creation of the AVF. Next. And at last, our committee of interventional nephrology of the Brazilian Society of Nephrology, we understand that the nephrologist, once trained for it, can do the surgery of AVF, and according to the literature and Brazilian regulation. The next. Well, summarizing, the scope of nephrologists in AVF access, we can do a functioning access monitoring, Doppler ultrasound evaluation, preoperative evaluation, and about the access surgery, we can also do the native AVF surgery as the AV graft, the post-operative follow-up, the treatment of complication, and endovascular treatment as well. The next, please. And concluding, the number of nephrologists around the world who create their own fistulas and grafts is growing, driven by a need for better patient outcomes and on hemodialysis. Nephrologists have also a key role for care of vascular access during hemodialysis treatment by following vascular access function using clinical data, physical examination, and additional ultrasound. The next, please. In the beginning, this was the scene commonly see. The vascular surgeon taking it as a fight, but we not think it at this way. I think we should be a team working for better outcomes for our patient. Each specialty in doing their job, but in common application for the patient. The next one. This is still me, beaten but happy, making the better for my patients. And if you make the final question of this presentation, the next, please. can nephrologists act in all vascular access process? I say, yes, we can, for sure. And I like to thank you very much for your time. And I'm here for any questions that you can have. Thank you very much.